what is your opinion on ICG-based sentinel lymph node biopsies being adopted as a standard of care in breast oncoplastic surgery?
So look, the Sentinel at present we are offering in two settings. One is early breast cancer and second is advanced breast cancer. So in early breast cancer, we are doing sentinel lymph node biopsy using the dual dye technique, either blue plus ICG or blue plus radioactive dye. So in the upfront surgery setting, there are a lot of data available for use of the ICG in node negative early breast cancer patient. We have published our data too. So we have published two data from our hospital. One first data we have published in American Society of Clinical Oncology Journal of Global Oncology in 2020, in which what we have done, we were using blue plus radioactive dye before 2017, and we were struggling to get radioactive dye even in the tertiary care center for the sentinel lymph node use. That's the thing, we moved to the ICG dye at that time. We were not knowing that this will be so fruitful in the next 10 years. So it's almost 8 years of our experience. So in this particular study, what we have done, we have compared the identification rate and the general diagnostic performance of blue plus radioactive dye. That's the standard or gold standard with the blue plus ICG dye. If I am saying blue, in the India, we use methylene blue dye and it has low hypersensitivity reaction. In our experience, we have not seen a single hypersensitivity reaction with the methylene blue dye. And in this study, what we found that the diagnostic performance of the ICG is either equivalent or better than the blue plus radioactive dye. Second study in consecutive, we have published our mega study of 1500 patients. In that, we have compared the four different methods: blue dye alone, radioactive dye alone, radioactive plus sentinel lymph node, and blue plus ICG dye. And what we found that the identification rate was best with the ICG, around 98% with our experience. It was between 90 to 95% in other methods. So blue was the least, then radioactive dye, then blue plus radioactive dye, and then blue plus ICG dye. So this is about upfront surgery. Second, come to the post-necessity. So post-necessity concept is, if it is a very limited node positive disease, give chemotherapy. And if they are converting to node negative, do sentinel lymph node biopsy post chemotherapy. So it's still not established around the world, the sentinel lymph node biopsy itself, because there is a high false negative rate with the sentinel lymph node. But if you see the ICG, the ICG is very ultra sensitive dye. So what we are trying to do, we are trying to use the disadvantage of the ICG as an advantage in the post-necessity setting. So at present, we are running a trial where we are doing sentinel lymph node biopsy in a node positive patient converted to node negative by blue plus ICG dye, and we are doing validation axillary dissection to see the false negative rate of sentinel lymph node biopsy. Because with the ICG, what happened, if you see our study of the upfront surgery patient, median number of lymph node what we removed is around 3.8. And it was found that in the post-necessity study that if you are removing 3 or more lymph node, false negative rate is less than 3%, less than 10%. So this disadvantage of the ICG we are trying to use as an advantage in the post-necessity sentinel lymph node biopsy. It's not a real disadvantage, I must say, because if you are removing less than 4 lymph node, you are not increasing the lymphedema. But the median number of lymph node removed by blue plus radioactive dye is around 2 or 2.5. But with the ICG is around between 3 to 4. The less than 4 is acceptable for the sentinel lymph node count. But in the post-necessity setting, it's is with our experience and our expectation with our trial that we may come up with that blue plus ICG dye is even superior to the blue plus radioactive dye in doing post-necessity sentinel compared to the gold standard.
Okay. Thank you, sir. Would you like to touch upon the other application being perfusion assessment in breast reconstruction surgery?
Yeah, so we have multiple use apart from Sentinel. Sentinel was the main use we thought of, but now we are using in multiple use. So in the breast cancer specific surgery, we do lot of flaps. So one is local flap that's known as chest wall perforator flap. Second is abdominal flap. So what we do after raising the flap, we inject the ICG dye IV. So here we are injecting IV injection. For Sentinel, we inject intraparenchymal or intradermal. So we use 1 ml of ICG and we see the vascularity. So what you need to do, you need to inject the dye and see with the perfusion that flap is glowing up with the fluorescence or not. And apart from that, we are using it in the nipple sparing mastectomy also, because in the nipple sparing mastectomy, what we do before starting operation, we inject IV ICG and we see the nipple vascularity and we mark the vessel, because ICG give you the clear cut that where the supply of the nipple is coming from. And during surgery, if I have marked that, I will be more careful in that area to not to damage that specific vessel. And after surgery also, we cross confirm it again by using IV injection. Third thing is that it's very useful if you are in a trouble. So suppose you are working in an institute and you have raised a mastectomy flap, and at the end of the surgery you are in doubt that your flap is not healthy. So at that time, ICG is very helpful. If it is available in your institution, what you can do, you can inject the ICG dye and you can see the flap vascularity, the mastectomy flap. And if you feel that the margins are not very vascular, you can trim it out and close the healthy margin. So it has multiple use apart from the sentinel lymph node biopsy in the breast cancer, whole oncoplastic breast surgery management.
Okay. Thank you so much for sharing your experience, sir, and giving us a comprehensive account of how ICG or image guided surgery benefits clinical practice. If there's anything else you would like to touch upon, we'd be more than happy to listen to it, sir.
I will request the surgeons all around the world. It's not about lower middle income country or the Indian country to think for the ICG overall, because it has multiple use. First thing. Second, it is of low cost. Third thing is that you don't need nuclear medicine setup to use this technology. Fourth thing is that it's surgeon dependent, so the whole thing is in control of your hand when you want to place the case. Suppose you want to do a case at 7 p.m. in the night, probably nuclear medicine facility will be not available at 7 p.m. But if you are a surgeon and the whole thing is surgeon dependent, you can schedule the surgery according to your schedule or your institution schedule or availability of the OT. So this is the growing technique. There is a huge interest around the world. I know that Japan and the many Southeast Asian countries have completely gone from the radioactive dye to the fluorescent dye in many of the use of the radioactivity, because ultimately you are preserving radioactivity also for the different use, the medical use, because the other use are also important, just like the bone scan and the PET CT scan. So you are preserving radioactivity used by, because radioactivity is very limited, we all know. So this is the technique. It should be adopted by all surgeon, and we are trying to develop a training program to empower surgeon to adopt this technique.
Thank you so much, sir. Thank you for being an early adopter and such a big support to the team here, and encouraging us in exploring newer technologies and developing them. Thank you so much.
Thank you very much.